Very good morning to all of you. Welcome to this 25 most important pediatric questions session. As promised today, we are meeting today morning with the 25 questions from pediatrics, which I feel are from all the topics which are very important for your FMG exams. So very good morning to all of you. I hope you are on the right path, preparing for your FMG exams. Now this is the time for your last minute preparations, and I am going to help you out in the pediatric part of your preparations. So please understand, these questions are not that important. What are most important are the topics from which these questions are taken. So although I will say these are the important pediatric questions, but more important are the topics from which these pediatric questions are taken. So milestones, short stature, infants of diabetic mothers, whatever questions we will be discussing, please just go through those topics from pediatrics. Just go through those topics just before your exams, because those are the topics I feel which are more important. So that is why I'm saying that questions are important, but more important are the topics from which these questions are taken. And I hope I will not be seeing you in the next session, because I know you all will be clearing your FMG exam. So that is why we do not want to, let me say this way, we do not want to meet next session, because I know you all are capable enough, you all are good enough for clearing your FMG exams this time. So best of luck for your FMG exams. You all will clear with very good passing marks, so don't worry. I know, I have that confidence in you. You have the confidence in yourself or not, I do not know, but I have the confidence in you. Given the preparations, the time and the efforts that all the faculties from NIST have put forward during the sessions, I saw our students were very attentive towards the lectures. Most of the students were very attentive towards the lectures. They were taking part in the pediatric sessions. At least I can tell about my classes. They were taking part in the pediatric sessions. Very good batches. Whichever batches I taught, very good batches. And I'm sure, going by the feedback that I received from other faculties also, I'm sure this time you all will be clearing your FMG exams. So let us start now with the pediatric questions. And I start with question number 1. So now question number 1 is again a topic which I personally feel is a very important topic. And if you see, every now and then you keep on getting one question on short stature in the FMG exam. So this question says, a child with short stature is brought for evaluation. His upper segment is smaller than his lower segment when compared to the other age-matched children. So broadly, he appears to have a disproportionate short stature, because if he would have been having an proportionate short stature, his upper segment and lower segment would have been matching with the other age-matched children. So he has a disproportionate short children. So if you remember, I had told you that short statures can be divided up into first physiological short statures and pathological short statures, and pathological short statures are further divided into proportionate and disproportionate short statures. So first of all, the first thing that should come to your mind, this is not a child with a proportionate short stature, this is a child with disproportionate short statures. Now, how did I tell you disproportionate short statures? How will we divide them? We divide disproportionate short statures into two segments, if you clearly remember. First was a child who has an infantile disproportion. Infantile disproportion, what does it mean? The upper segment is big, lower segment is short. And the second is a child who has an advanced disproportion. What does advanced disproportion means? Upper segment is small, lower segment is big. So now you are having a child whose upper segment is small, lower segment is big. This very clearly is telling you, first, this is a child with short stature. Second, this is a child with a disproportionate short stature. And third, this is a child with advanced disproportion. Just move logically in your exams. When you are approaching a question, just move logically. These three things I could get very clearly within the first minute of reading that question. This is the short stature, this is a disproportionate short stature, and this is an advanced disproportion. Now they are asking most likely cause of short stature is, and as most of you have correctly pointed out, it cannot be a familial short stature. First, there is no family history given in the question. Second, it is a disproportionate short stature. Constitutional delays are again disproportionate. They are unlikely to be, again proportionate. They are unlikely to be disproportionate. Now, these are the two examples of disproportionate short stature. One is achondroplasia, one is spondyloepiphyseal dysplasia. And out of them, achondroplasia is an example of a child with infantile disproportion. Infantile disproportion means the child has a long upper segment, short lower segment. And second is spondyloepiphyseal dysplasia, which is an example of advanced disproportion, which means the upper segment is short and the lower segment is big. And therefore, according to me, this should be the correct answer. And I'm very happy to see that most of you, nearly most of you have given you the correct answer. That means the approach to this question, I know these questions were not given out to you. I know the answers of these questions were not given out to you. So I'm very happy to see most of you who have attempted this first question have given instantaneously the correct answer, which is a spondyloepiphyseal dysplasia. So very good. So let us revise once again. How do you divide short statures? Short statures are divided up into physiological short statures and pathological short statures. No need to make this. This is just a revision because this is an important topic for your exams. Physiological short statures are also divided up into familial short statures and constitutional delays. As I had told you, constitutional delays are sometimes also referred to as constitutional delays in growth and puberty. Constitutional delays basically is a condition which is associated with a delay blooming of the child, which means the child's growth is usually starting but is starting later than the normal time. And most of these children have a delay in the puberty also. So familial and constitutional delays usually are physiological short statures and unlikely to be cases of a disproportion. So now how do you divide pathological short statures? One is proportionate short statures and one is disproportionate short statures. And as I told you, disproportionate short statures, they go in their cars, while proportionate short statures, they walk on their feet. So what were the examples of disproportionate short statures? First is congenital hypothyroidism, second is A, achondroplasia, third is R, rickets, and fourth is S, spondyloepiphyseal dysplasia. While the first three, congenital hypothyroidism, achondroplasia, rickets are example of infantile disproportion, which means long upper segment and short lower segment. The last one, which is spondyloepiphyseal dysplasia, is an example of advanced disproportion, which means a short upper segment and a long upper segment. So be very careful about the question. Proportionate, disproportionate. If disproportionate, infantile, advanced, and then you immediately come to the correct answer. And for proportionate short statures, the causes are feet, which I told you, food, malnutrition, endocrinal disorders. Then another E stands for chronic extended diseases, and then T stands for Turner's or chromosomal disorders. So this should be an approach to short stature, and the correct answer should always be given after carefully evaluating the question. Are you all, those who are attending this session, are you all now confident in short statures? Let me see your answer. Are you all confident in answering short stature questions now? Because you will keep on getting short stature questions every session or every alternate session in your exams. So let me see this way. Are you all, before I move to question number 2, are you all comfortable in answering questions on short statures? Because that will give me sort of confidence also. We take short stature as a very, very important A+ topic in terms of importance for your FMG exams. Very good. Very good, very good. Now let us come to question number 2. A 2-year-old child is expected to have achieved all of the milestones except. So now another very important topic for your FMG exams, milestones. Very important topic. Now you just have to remember the timing by which the milestones appear. So climbing stairs one step at a time. Climbing stairs one step at a time should appear at the age of, when the child starts to climb, one step at a time. So this should appear at the age of 2 years, because the child is taking one step at a time to climb the stairs. Child usually rides a tricycle by the age of 3 years, and usually a bicycle by the age of around 6 years. So tricycle by around 3 years, and child learns to ride a bicycle by around 6 years. Child learns to copy a line again at the age of 2 years. So line at the age of 2 years, circle at the age of 3 years, square at the age of around 4.5 years, triangle at the age of around 5 years, hexagon at the age of 6 years, then rhombus at the age of 7 years, cylinder at the age of 9 years. So the child can copy a line at 2 years, and the child can walk without support, often by the age of around 13 to 15 months. That means around 1 year plus, the child can start walking without support. So as you can see, most of the milestones that I have written are likely to be achieved in a child by 2 years of age, except riding a tricycle, which will only appear at the age of 3 years. So that is why B is the correct answer, and you have correctly given B as the correct answer. So some of the milestones which are very important for you, let us revise some of those milestones. In gross motor milestones, which are the milestones which are important for you? Gross motor. So milestones which are important to you, for you in gross motor are sitting, crawling, creeping, and walking. So sitting without support and sitting with support. So when does a child sits with support for the first time? Around 5 to 6 months. So 6 months he is sitting in a tripod position. And when does the child sits without support? By 8 months. When does the child crawls? 8 months. When does the child creeps? 10 months. When does the child stands? 9 months. That is with support. But when does he stand without support? It is at 12 months. When does the child starts to walk? 10 to 11 months. But when does the child starts to walk without support? 13 to 15 months. So for your exams, just remember an important milestone as 6, 8, 10. 6, 8, 10. 6 will be associated with sitting. So first time sitting by 6 months, 5 to 6 months. Then 8 months will be crawling. And 10 months will be somewhere between standing and walking. So 9 months standing and 10 months walking with support. So 6, 8, 10. 6 is sitting, 8 is crawling, and around 10 months is standing and walking. Just remember like this. Coming now to when does the child starts climbing the stairs? So child starts climbing the stairs from the age of 2 years. But his climbing is different from how we climb. So by 2 years he is climbing one step at a time. By 3 years he goes upstairs, normal. But coming downstairs, again he is walking one step at a time. And 4 years he is walking normally upstairs and downstairs. Now let us revise the fine motor milestones, the grasp. So ulnar grasp, 6 months, radial grasp, 8 months, pincer grasp, 9 months, but a mature pincer grasp, 12 months. So 6, 8 and 9. 6 months, 6 to 7 months ulnar, then radial around 8 to 9 months, and pincer grasp will be around 9 months. Pincer grasp mature will be around 12 months. Then I've already told you, child starts to copy a line, 2 years, circle 3 years, square 4.5 years, triangle 5 years, hexagon 6 years, rhombus 7 years, and cylinder 9 years. Then turning each page of a book individually will be at 2 years. Coming to language. So language milestones simply will be, and there is another question on language milestones a little later. So simply will be cooing, vocalizing, babbling, jargons and sentences. So cooing at 1 month, vocalizing at 3 months, babbling at 6 months, jargons at 15 months, and sentences at 2 years. Cooing at 1 month, you can revise with me. Cooing at 1 month, then vocalizing at 3 months, then babbling at 6 months, then jargons at 15 months, and then sentences at 2 years. Coming to social milestones. In social milestones, the important social milestones are social smile, which is around, so child is recognizing the mother also, and the child is showing a social smile also. So while at 6 to 8 weeks, the child shows a social smile and he recognizes the mother slowly by 3 months. Then the child starts to play with his mirror image. Another very important question. When does a child stands in front of a mirror and plays with the mirror image? So that is roughly by around 5 to 6 months. Mouthing by around 5 months. Casting, throwing objects by 12 months. Then the child is able to identify colors by 3 years. He is able to identify his name by around 3 years. Then he becomes right-handed, left-handed by 3 years. Riding a tricycle by 3 years. Riding a bicycle by around 6 years. Stranger anxiety, again a question that has been asked in the exams, develops by the age of around 6 to 7 months. Then complete bladder control develops by the age of around 5 years, but a complete bowel control develops by the age of 4 years. So bladder control, 5 years. So if a child does not develop a complete bladder control and continues to bedwet, he will be called or she will be called as a case of enuresis. Enuresis at night, nocturnal enuresis or diurnal enuresis. Diurnal enuresis is daytime bedwetting also. And if the child continues to pass stools at inappropriate places, so now bowel control, not achieved by 4 years. So that will be called as encopresis. So encopresis diagnosis should be made after 4 years. Enuresis diagnosis should be made after 5 years. So these are the important milestones which I feel are important from your examination point of view. Right? If you have been in front of me, I would have definitely been revising all this by asking you the questions and answering, and you answering me back. But since that is not possible in this YouTube session, so that is why I have just revised, and I hope you all at home will be revising with me. Let us now move on to question number 3. So milestones, another important topic for your exams. A 4.5-year-old child with 3 days history of diarrhea and perioral dermatitis. Now very important, perioral dermatitis, and the word perioral dermatitis should immediately strike here. Either a picture given of a perioral dermatitis, also called as periorificial dermatitis. When I say periorificial dermatitis, that means these nasolabial folds are also affected. So a dermatitis involving the perioral area, along with alopecia, which is loss of hairs, and diarrhea. So DDD, diarrhea, dermatitis, and then dementia does not occur in children, but loss of hairs, alopecia. So DAD now in children. That is more commonly a feature of zinc deficiency. So I have told in my classes, DAD, zinc deficiency, diarrhea, alopecia, and dermatitis. And this dermatitis is usually perioral dermatitis, also sometimes called as periorificial dermatitis. It can also be a perianal dermatitis. So sometimes around the anal orifice also, if there is a redness, scaling, dermatitis type of presentation, and the child alongside has diarrhea and loss of hairs, think of the child having a condition called as acrodermatitis enteropathica. Acrodermatitis enteropathica. It's an autosomal recessive disorder which is associated with zinc deficiency in the body. So this is a deficiency of zinc. As you have correctly pointed out, it is a deficiency of zinc. So I have told in my classes, zinc deficiency is associated with a condition which is called as acrodermatitis enteropathica. Copper deficiency in the body is associated with a condition known as Menkes disease. And Menkes disease again is a disease which is quite commonly asked in the exam. So you should be very familiar with Menkes disease. Menkes disease is a disease which is basically associated with a deficiency of copper in the body. So children with Ming's disease require lifetime copper administration because these are the children who have a deficiency of zinc. In contrast, Wilson's disease is associated with copper excess in the body. So those children do not require copper. They actually require copper chelators to bind copper because of the excess amount of copper which is presenting in the body. So again, be very careful. Wilson's disease is copper excess. Ming's disease is copper deficiency. Ming's is again ATP7A mutation and the other is ATP7B mutation. So be very careful about the question. First, are they asking deficiency or excess? Then which micronutrient deficiency they are asking. Acrodermatitis enteropathica typically is associated with diarrhea, alopecia, dermatitis plus some other manifestations, but main manifestation should be diarrhea, alopecia, dermatitis. And our question, all the three are present. Copper deficiency is more commonly, Ming's disease is more commonly associated with a quite serious illness which is basically associated with neurodevelopmental delays in the child. So the child has neurodevelopmental delays, may have seizures also, and there are typical changes in the hair. So hair shafts are twisted, hair shafts are distorted, hair shafts may be broken, there are patches of hair loss also. So all of these are present in copper deficiency, which is called as Ming's disease. Ming's disease diagnosis actually require a hair biopsy also. So they are very typical hair changes. And these typical hair changes on microscopy are sometimes also referred to as pili torti, which are seen in Ming's disease. Pili torti is not exclusive to Ming's disease. These type of microscopic changes in the hair can be seen in some other conditions also. But as far as I know, in terms of micronutrient deficiencies, copper deficiency or Ming's disease is the only condition which is associated micronutrient deficiencies. It is the only condition associated with pili torti. What is pili torti? It's the microscopic, it's a name given to microscopic changes, histopathological changes that are actually seen in children who have Ming's disease. It is basically hair shaft changes. Hair shafts are distorted, hair shafts are broken at regular intervals, and pili torti can be seen, as I told you, in some other conditions also, but not other micronutrient deficiencies. So Ming's disease requires a hair biopsy also to identify these changes. Diagnomonic, yeah, very good. Ming's is also, yes, called as kinky hair disease. Again, because of the typical type of hair changes and the typical hair appearance that is seen in, it's quite a fatal illness, and as far as I know, by 4 to 5 years of age, a large number of children, maybe around 20 to 30% of children, may have mortalities also if not given a proper care. So this is an illness which is a serious illness. In terms of treatment is lifetime copper administration. Coming now to question number 4. Question number 4 says, dark brown discoloration of the skin is seen in a newborn, and this can be seen as a complication of which of these neonatal procedures? So there is a child who has developed a dark brown color discoloration or patches of dark brown patches over the skin area of a newborn. So they are asking, this can be a complication of neonatal positive pressure ventilation, ambu bags, or is it as a complication of blood sampling in a newborn, or is it a complication of exchange transfusions, which is an exchange of the newborn blood with another compatible blood which is brought from the blood bank, as is done in cases of neonatal jaundice, or is it a complication of phototherapy? And you are all correct, it's a complication of phototherapy. This complication is also known as the bronze baby syndrome. It's also called as the bronze baby syndrome. Very good. Please don't confuse it with the grey baby syndrome. Grey baby syndrome is a complication of chloramphenicol toxicity. But bronze baby syndrome is a complication of phototherapy. And for your exams, again, you should be very clear about complications of phototherapy. So the complications of phototherapy, The complications of phototherapy can include diarrheas, which is because of bile salts. Then it can also lead to dehydration. Phototherapy can also lead to hypocalcemia. Then it can also, as I just now told you, lead to bronze baby syndrome. And it can also lead to retinal damage. So these are some common complications which can be associated with phototherapy. A lot of diarrheas can happen in these children with phototherapies. And because of diarrheas, these children often can develop dehydration under that phototherapy light. Hypocalcemia is quite common in these cases. A complex mechanism, but phototherapy light can lead to hypocalcemias also. And one has to be very careful when a child is being given phototherapy to avoid the child developing a seizure because of hypocalcemia. Then bronze baby syndrome. Now, bronze baby syndrome is brown colored discoloration or patches, as you are seeing in the question. So these are brown colored discoloration or patches which develop on the skin when newborns are kept under the phototherapy light. And it's not very common. It can develop only in select newborns, but is more likely to occur in newborns who have a pre-existing obstructive gastrointestinal disorder. So any patient or any newborn who has a pre-existing cholestatic disorder or an obstructive gastrointestinal disorder or an obstructive biliary tract disorder, these newborns are more likely to develop a bronze baby syndrome under phototherapy light. So it does not develop in all newborns. What all other questions can be asked in phototherapy? So phototherapy is one of the best treatment options for neonatal jaundice. Phototherapy often is known to reduce bilirubin by three mechanisms: structural isomerization, configuration isomerization, and photooxidation. And let me see if you remember which is the most important mechanism by which phototherapy reduces jaundice. Is it structural isomerization mechanism? Is it configuration isomerization mechanism? Or it is photooxidation mechanism? Let me see if you remember. Is it structural isomerization mechanism, which is the predominant mechanism by which bilirubin is reduced? Is it configuration isomerization mechanism? Or it's photooxidation mechanism, which is the predominant mechanism by which phototherapy is known to reduce neonatal jaundice? Let me see. Very good. It is structural isomerization mechanism. So the predominant mechanism by which phototherapy is known to be effective is the structural isomerization mechanism. In structural isomerization mechanism, the bilirubin is converted into a structural isomer of bilirubin. What is the name of that structural isomer of bilirubin? Let me ask that question also. In structural isomerization mechanism, bilirubin is converted into a structural isomer of bilirubin. What is the name of that structural isomer of bilirubin? So you can be asked that question also. What is the name? I have told in my classes also. What is the name of that structural isomer of bilirubin that is soluble and is excreted out? So that is why there is reduction in the bilirubin levels in the body. Very good. It is lumirubin. Very good. It is lumirubin. So you can be asked this question. Lumirubin is a structural isomer of bilirubin formed under phototherapy. So this lumirubin is primarily, the formation of lumirubin, which is soluble and can be excreted out, is primarily the mechanism by which phototherapy reduces neonatal jaundice. Very good. You have all given correct answer. In configurational isomerization, the Z isomer of bilirubin converted into the E isomer of bilirubin, and in photooxidation mechanisms, photooxidized products are formed. So ultimately, what is phototherapy doing? It is forming soluble bilirubin isomers and prompting those soluble isomers to be secreted out. That is basic, or excreted out, the correct word. And that is why This is one of the very effective methods by which bilirubin is reduced in neonatal jaundice. The phototherapy light that is used has a wavelength of 460 to 490 nanometers. So we primarily use the blue wavelength. So the blue light is primarily used to reduce the neonatal jaundice or neonatal bilirubin. The various type of bulbs can be used for phototherapy light. Ultimately, phototherapy is a very, very effective mechanism. The only complications that can occur, I've given that in front of you, and bronze baby syndrome occurs in children who have a pre-existing obstructive liver or biliary tract disorders. So, very good. Most of you have given correct answers, rather all of you have given correct answers. So, I hope now you are all confident in answering a question on phototherapy related topics also. Jaundice, neonatal jaundice, what can be asked? Physiological, pathological. I was seeing a day before, they asked which of the following is not a criteria for physiological neonatal jaundice. So just revise with me. Physiological neonatal jaundice appears on day 2 to day 3 of life. Physiological neonatal jaundice normally disappears by a max of 2 weeks. Most physiological neonatal jaundice will disappear by 1 week. But even if a neonatal jaundice persists till 2 weeks, it will be called as a physiological neonatal jaundice. And if a jaundice in a newborn is persisting beyond 2 weeks, then it will definitely be called as a pathological neonatal jaundice. Although you do have, as I told you in my classes, you do have some cases of breast milk jaundice which are not truly pathological but may persist for long periods of time. But ultimately, most jaundice in newborns which persist beyond 2 weeks are called as pathological. And if that pathological jaundice which is persisting beyond 2 weeks is primarily conjugated, then that disorder, as I told you, is called as neonatal cholestatic disorder, neonatal cholestasis. So neonatal cholestasis are those neonatal jaundice which persist beyond 2 weeks and are primarily caused by some obstruction in the liver or biliary tract, leading to mainly conjugated bilirubin fraction increased. So physiological jaundice, pathological jaundice in newborns. Pathological jaundice can be unconjugated, conjugated, sometimes mixed. Conjugated pathological jaundice persisting beyond 2 weeks is called as neonatal cholestasis. Neonatal cholestasis means there is some cholestasis, obstruction. Now that obstruction can be intrahepatic, it can be extrahepatic. And as I've told you, the two most important causes of neonatal cholestasis are either neonatal hepatitis or a biliary atresia. So these are the two most important causes of neonatal cholestasis, with neonatal hepatitis slightly more common in comparison to biliary atresia. Biliary atresia, again, another important question for FMG exams, is one of the most important causes. Rather, if I correctly remember, your surgery faculty, Dr. Vineet, will be able to tell better. But according to me, children who have obstructive conditions such as biliary atresia. So biliary atresia is the most important cause for liver transplants in children. So the most important indication, according to me, for performing liver transplants in children is biliary atresia. So in this discussion, I think we have discussed several points which are important from your FMG exams point of view. I hope you will remember all these points, and some of the points I hope will be asked in this coming exam. Okay, coming now to question number 5. A sister on duty in NICU has taken routine readings and has shown the reports of a 33-week neonate to the neonatologist. So you are a neonatologist, a person who is specialized in treating newborns. You are sitting in the NICU and there is a sister who has come to you with a report of a 33-week newborn. So be very careful. This newborn is a 33-week newborn, which means the newborn is a preterm newborn. So the newborn is a preterm newborn. So the newborn's temperature is 36.2 degrees. So does he have hypothermia or does he not have hypothermia? If you remember, I told you in my classes, a temperature between 36.5 to 37.5 degrees is considered as normal temperature in newborns. Below 36.5, you start categorizing it as hypothermia. So this newborn definitely has hypothermia. And which type of hypothermia is this? Since it is till 36.1 is hypothermia, 36.1 to 36.5, 36 to 36.5 broadly, but more accurately 36.1 to 36.5. So this is definitely a case of mild hypothermia, cold stress. Moderate will be between 32 to 36 and less than 32 will be severe hypothermia. So this definitely has hypothermia. Then the heart rate. The heart rate of this newborn is 142 by 142 per minute. So is this a normal heart rate or is this tachycardia or is this bradycardia? No, this is not a tachycardia because as I've told in my classes, normal heart rate of newborns is between 110 to 160 per minute. So till the time the newborn's heart rate goes above 160, we will not call it as tachycardia. So this is not a tachycardia at all. This is a child who has a normal heart rate. So this is a normal heart rate, not a tachycardia at all. Then this newborn has a respiratory rate of 55 per minute. Would you call it as a tachypnea, a fast breathing? No. The definition of tachypnea, as I've told you, fast breathing. The definition of fast breathing, as I've told in my classes, are a respiratory rate more than 60 per minute in children till 2 months, more than 50 per minute in children between 2 to 12 months, and more than 40 per minute in children between 1 to 5 years. So this is definitely not tachypnea in a newborn, because a newborn, you will expect the tachypnea to be only when the respiratory rate is above 60 per minute, and they have the respiratory rate is 55 per minute. So this is not tachypnea also. So this is normal respiratory rate. Then blood glucose of the child is 52 milligrams per deciliter. Now, as I have told you, only when the blood sugar of the newborn develops or becomes less than 45. Now it is debatable. In some books they write less than 40 milligrams per deciliter. In some books they write less than 45 milligram per deciliter. We'll follow less than 45. Rather than being confused, it is better to follow what is usually given in most books. And most books say less than 45. That is what we follow in our treatment protocols in our hospitals also. But in many places, you will get it as less than 40 milligrams per deciliter also. So it's a little confusing. But I will say blood sugar, and I've told this in my classes, blood sugar less than 45 milligram per deciliter in a newborn will be called as a neonatal hypoglycemia. And here, as you can clearly see, it is a normal blood glucose. This is not a blood glucose which is low. It is normal blood glucose. Now finally, the serum calcium. Now, serum calcium is 6.9, and as I have told in my classes, for a preterm, a serum calcium less than 7, and for a term, serum calcium less than 8 will be called as hypocalcemia. And since this is a preterm child, I would expect his serum calcium to be more than 7, not less than 7, and this is clearly a serum calcium less than 7. So this is definitely a case of hypocalcemia. So I am having a newborn who is hypothermic, hypocalcemic, but otherwise has a normal heart rate, normal respiratory rate, and has a normal blood glucose. And therefore, the only correct answer, very good, all of you have given the correct answer. The only correct answer is hypothermia and hypocalcemia is present. The child does not have tachycardia, the child does not have tachypnea, and the child does not have hypoglycemia. So general neonatology values should be known to you. Please be very, very familiar with the normal values in newborns. Respiratory rate, revise with me. Respiratory rate 40 to 60 per minute. Heart rate 110 to 160 per minute. Normal length 50 centimeters. Normal head circumference 35 centimeters. Normal temperature 36.5 to 37.5. Normal upper segment to lower segment ratio 1.7:1. Normal blood glucose more than 45. Normal calcium more than 7 in the case of terms, in the case of preterms, and more than 8 in the case of terms. So please remember these values, as these values are very important for your exams, and any questions such as these can be asked on these values. So all now confident in neonatal values, basic neonatal values. Let me see your confidence. Let me see if you have written that down in the feedback section, in the chat section. All confident, familiar with the normal values of newborns, normal length, normal head circumference, normal heart rate, normal respiratory rate, normal upper segment to lower segment, normal temperature. Then similarly, low birth weight definitions, very low birth weight definitions, extremely low birth weight definitions, definitions of SGA, definitions of LGA, definitions of AGA, definition of preterm, term, postterm. Very good. Because sometimes what happens is we keep on going deeper and deeper in our studies and forget what are the basics required. And these are the basics in neonatology, normal values. All respiratory disorders, all gastrointestinal disorders, all CNS disorders, they come later when you know what are the normal values. So I gave this question specifically so that you are familiar with the normal values. And I see yes, very good, normal values. Let us now come to question number 6. Question number 6. Question number 6 says all of the following are true for respiratory distress syndrome. So respiratory distress syndrome is the most common cause. It's the most common cause of respiratory distress in preterms, especially preterms who are less than 34 to 35 weeks gestation. Most common cause. It is primarily a result of surfactant deficiency. Surfactant deficiency reduces the surface tension, prevents alveoli from collapsing. So surfactant basically reduces the surface tension and prevents the alveoli from collapsing. So if there is a surfactant deficiency, the alveoli are likely to collapse, resulting in episodes of breathing difficulty in preterms immediately after birth. It does take around 4 to 5 hours in some newborns, but usually within 6 hours of birth. In most cases of preterms, respiratory distress will develop if they have an RDS. Now, what are the chest X-ray features of RDS? I've told you the chest X-ray features of RDS. Okay, let me start first with what is RDS. So, what is RDS? I've already told you. Okay, let me better revise with the differences between the two most common type of disorders, RDS and TTNB newborns. So these both are causes of respiratory distress in newborns. So this is primarily a disorder that is seen in preterms, usually less than 34 weeks or less than 35 weeks. TTNB is more commonly a problem that is seen in terms. It can also be seen in late preterms. Late preterms means 35 to 36 weeks. But more commonly a problem seen in terms. RDS usually occurs because of surfactant deficiency, while TTNB, transient tachypnea of the newborn, is more commonly because of the persistence of the fetal lung fluid after birth. So normally after birth, the fetal lung fluid should have disappeared by mechanisms which I have already told in my classes. But if that fetal lung fluid in the alveoli does not disappear, it provides no space for the air to enter when the child cries after birth. And that is why the child develops a transient difficulty in breathing after birth, which is called as a TTNB. RDS can be a cause of serious respiratory disorders where there have been mortalities also. Sickness can be severe, hospitalizations can be prolonged, NICU requirements are there. But usually this is a condition, TTNB is a condition which is usually a transient respiratory disorder. Usually. We have seen in very rare cases TTNB deteriorate also, but usually it's a very transient disorder. That is why the name transient tachypnea of the newborn. The chest X-ray features of RDS normally includes, as I've told in my classes, reticulogranular opacities, ground glass opacities, air bronchograms. Reticulogranular opacities, ground glass opacities, and air bronchograms. Normally you get very, very little air inside the lung fields in children with RDS. TT&B chest X-ray, however, will show fluid inside the lungs. So these fluid are normally arranged around the horizontal fissures of the lungs. So they make the horizontal fissures of the lungs very prominent. So prominent interlobar fissures are the features that can be seen in TT&B. Sometimes increase in the pulmonary vascularity around the hilum can also be seen in TT&B. So there is a lot of vascular markings around the hilum, which often gives a name, or which is often given a name, which is called as sunburst appearance or starburst appearance. So sunburst or starburst appearance can also be a feature of TT&B. It's not a very well described feature. More important feature is prominent interlobar fissures. But because of increased vascularity in the lung fields around the hilum, it is sometimes also given a name starburst and sunburst appearance. Sometimes small amount of fluid can be present in the pleura also, but that's it. The treatment of RDS usually involves either CPAP, continuous positive airway pressure, and in most serious cases of respiratory distress or respiratory failure, mechanical ventilation. Surfactant can be administered, and there are very well-defined features or very well-defined criteria rather in which surfactants are given. Surfactants usually can be given in terms of treatment, but sometimes can be given for prophylaxis also. So if there is a child who is an extremely premature child, such as a child who is less than 28 weeks, so this child is so premature, less than 28 weeks, he is called as an extremely premature child, that in these cases, sometimes in some institutions, surfactant can be recommended as a prophylaxis also. So give before the condition of the child deteriorates. So you know that this child may deteriorate because he is less than 28 weeks. So in such cases, you do not wait for the child to deteriorate. You rather will give it as a prophylactic agent. In most other cases, surfactant is given as a therapeutic option. That means when deterioration or when respiratory distress starts becoming more severe. The treatment for cases of TT&B is usually symptomatic management. As I said, transient tachypnea. So most of these cases will recover on their own by 2 to 3 days time. Unlike in cases of RDS, which require specific management. And surfactant in RDS can be given, as I told you, by a classical technique which was known as the in-show technique. But the two less invasive techniques which are being used are the MIS technique, minimum invasive surfactant therapy, and also sometimes the LISA technique, less invasive surfactant administration. I think they asked this question also. LISA is a procedure for administration of. So answer is surfactant. The full form of LISA is less invasive surfactant administration. The full form of MIST here is minimum invasive surfactant therapy. Coming now to question number 7. A term newborn develops abdominal distension after birth. So there is a term newborn who has developed abdominal distension after birth. He does not pass meconium even after 48 hours. So should have passed meconium after 48 hours, but he does not pass meconium even after 48 hours. Mother has a history of type 2 diabetes. Now this is a very important history. Mother has a history of type 2 diabetes. So this is a child who is born to a diabetic mother. The mother is currently on anti-diabetic drugs. So they are saying the most likely cause for this neonatal disorder. What's the cause of the neonatal disorder where the child develops abdominal distension, he is not passing meconium, and he is born to a diabetic mother? So the 3 clues are there. First clue is this is a term newborn. Had it been a preterm newborn, we would have gone in for some other causes, especially for abdominal distension and not passage of meconium. But this is a term newborn. So term newborn delivered to a diabetic mother. Second clue, very important. Why will they give diabetes They will give diabetes because there is something related to diabetes, wherein in some newborns the child may not pass meconium even after birth. And the third important clue is that the child is not passing meconium, which means it is a type of delayed meconium passage. So there are so many causes of delayed meconium passage. It can be anorectal malformations, anal stenosis. It can be cases of duodenal atresias, jejunal atresias. It can be cases of Hirschsprung disease. It can be different causes. But what is the cause which is most important cause in terms of child born to a diabetic mother? So let me see what now here there is most of you have answered it as B, meconium ileus, but please remember meconium ileus is more commonly a problem of cystic fibrosis. It is not a problem related to infants of diabetic mothers. It is more commonly related to cystic fibrosis. And here there is no history of cystic fibrosis. Here what is more important according to me is a history which is type 2 diabetes. Mother type 2 diabetes, child born with type 2 diabetes develops a disorder which is called as the small left colon syndrome. Small left colon syndrome. It has in the past been called as a lazy colon syndrome, but now it is called as small left colon syndrome. I don't know, in my classes, I have often given the answer. I've often told this, haven't in my classes, I've mentioned about left colon syndrome being an important disorder which is associated with infants of diabetic mothers. I think I've told you, complications in infant of diabetic mothers, remember from my classes. LGA, then congenital malformations such as neural tube defects, then congenital heart diseases, then sacral agenesis, caudal regression syndrome, then small left colon. I've given this again and again in my classes, small left colon. Haven't I given small left colon in my classes? Those who have attended my classes, do you remember? I'm sure some of the students who are attending the session, maybe those who have attended my classes. Do you remember small left colon as a complication written under complications in infant of diabetic mothers? When I'm teaching infants of diabetic mothers, I will not miss out on a small left colon. It's not a very, first let me say, it's not a very common condition. But even though it's not a very common condition, you can always expect it to be asked in the exam, because in the exams, they often ask things which are not very common. They want to test your knowledge, your information about those things which are not so common. I do remember having mentioned multiple times in my classes about a type of a disorder which is a functional intestinal obstruction. It's not a structural obstruction. As the name suggests, small left colon. So the problem is mainly in the left colon, distal to the splenic flexure. So the problem is in the left colon. Now this left colon develops a functional obstruction. That means it is not contracting properly. It will soon contract properly after birth, but it will take some time. And during that time, most of these newborns immediately after birth may develop abdominal distension, may not be able to pass the meconium after 48 hours. And this condition is called as the neonatal small left colon syndrome. Don't confuse it with meconium ileus. Meconium ileus, I have told again in my classes, is related to cystic fibrosis. Now you are coming near the end of your preparations. Now your exams are starting. Don't confuse things. Meconium ileus I have never mentioned in my classes under type 2 diabetes complications. I mentioned meconium ileus very clearly in cystic fibrosis. If you remember cystic fibrosis, I told you about problems in respiratory tract, airways, obstructions of the pancreatic duct, obstructions of the bile duct. When I told you about intestinal obstructions in cystic fibrosis, I've clearly mentioned the most important neonatal complication of cystic fibrosis is meconium ileus. Don't think about meconium ileus anywhere else, usually, except cystic fibrosis, usually. And small left colon, type 2 diabetes. This is a very common link. Don't forget this link. So let us revise very quickly, just very quickly revise complications in infants of diabetic mothers. First is LGA, large for gestational age babies. Second is congenital problems. So those congenital problems can be neural tube defect. Most common complication in infants of diabetic mothers, neural tube defects. Then congenital heart defects. Most common congenital heart defect is VSD. So both VSD and neural tube defects are very, very common complications seen in infants of diabetic mothers. Most specific congenital heart defect is TGA, but most common congenital heart defect in infants of diabetic mothers is VSD. Least common congenital heart defect in infants of diabetic mothers, ASD. Then I've also talked about the most specific complication in infant of diabetic mothers, which is caudal regression syndrome. So most common NTD, neural tube defect, most common congenital heart defect, VSD, most specific congenital heart defect, TGA, and most specific complication overall is caudal regression syndrome or sacral agenesis. Then one of the most common causes of child not passing meconium after birth in an infant of diabetic mothers is small left colon, functional intestinal obstruction in the left colon, distal to the splenic flexure. Type of functional intestinal obstruction, the child will recover, but will recover later than the normal time. Apart from this, there are some other complications also which will occur in infants of diabetic mothers, but these are the ones that you should remember for your exams. Question number 8. During routine evaluation of a neonate in the resuscitation room, the pediatrician identifies presence of a single umbilical artery. Now this is another clue. The child has a single umbilical artery. Normally, how many arteries do you expect in the umbilicus? So in the umbilical cord, you have 2 umbilical arteries and 1 umbilical vein. So you can be asked questions on umbilical cord. 2 umbilical arteries, 1 umbilical vein. Around it is the Wharton's jelly. The umbilical cord normally is cut immediately after birth or little after birth. So is it an early cord cutting that is recommended or slightly delayed cord clamping? So normally the cord clamping and cutting should be slightly delayed, which is usually around 30 seconds to 1 minute after birth. Then another very important thing for you to remember is, suppose there are no 2 umbilical arteries but a single umbilical artery only. Which congenital disorder would you expect? So we expect either a congenital renal disorder, genitourinary disorder, or you expect congenital heart defects. So which are the 2 most common congenital abnormalities associated with a single umbilical artery? One is congenital genitourinary abnormalities, and the second one is congenital heart defects. And I've told in my classes, yes, unilateral renal agenesis is the most common problem among the options given, which can be associated with the single umbilical artery. So you expect congenital genitourinary defects, you expect congenital heart defects, and sometimes you might expect congenital gastrointestinal disorders also. But mostly these are the 2 which are the most common. And among the 2, I would say still that kidney disorders are quite common, among which unilateral renal agenesis is very common. Unilateral renal agenesis is also associated with the syndrome. Which syndrome is associated with unilateral renal agenesis and which syndrome is associated with bilateral renal agenesis? Let me check if you remember or not. Which syndrome is most commonly associated with unilateral renal agenesis and which syndrome is commonly associated with bilateral renal agenesis? Which syndrome is most commonly associated with unilateral renal agenesis and which is associated with bilateral renal agenesis? Let me see if you remember. Which syndrome is most commonly associated with unilateral renal agenesis? Potter's is bilateral. Very good. And unilateral is? Potter's is bilateral. Unilateral is? You are giving me the answer. Potter is bilateral. Which syndrome is most, again I have told in my classes, which syndrome is most commonly associated with unilateral renal agenesis? Forgotten. At least those who have attended my classes should know that. It is Bechtel syndrome. So while Bechtel syndrome is most commonly associated with unilateral renal agenesis, Potter syndrome is most commonly associated with bilateral renal agenesis. So Bechtel syndrome is most commonly associated with unilateral renal agenesis, and Potter syndrome is most commonly associated with bilateral renal agenesis. No butters, no butter. Butter is not associated with any of these, unilateral or bilateral. Most common syndrome associated with unilateral renal agenesis is Bechtel. Most common syndrome associated with bilateral renal agenesis is Potter. Okay, remember for your exams. I thought you will immediately come up with the answer. Anyway, let us now move on to question number 9. Question number 9 says a child is brought for evaluation in the OPD with history of breathing difficulty, and the child has developed a bluish discoloration of the skin that has been progressively increasing in severity after birth. So this is an indication that the child is having a cyanotic disorder, because this bluish discoloration is a cyanotic disorder. So this means the child has a cyanotic disorder. Now they are saying the child has come with a type of a chest x-ray which is very, very clearly showing you a typical appearance. Which type of appearance can you see in the chest x-ray? Which type of appearance are you seeing in the chest x-ray? So I have told in my classes that a child who has a sign of 3 appearance indicates a coarctation of aorta, then boot-shaped heart indicates a child who has TOF, then box-shaped heart indicates a child who has Epstein's anomaly, then Egon string indicates a child who has a TGA, and a snowman heart or a figure of 8 indicates the child has a TAPVR, specifically a supracardiac TAPVR. So as I think most of you have correctly seen that, so I've again discussed about this in my classes, and as you have correctly seen here, this is a typical example of, this is not boot-shaped heart. Axis is downwards, and boot-shaped the apex will be upwards. So this is a typical egg on a string appearance. This is typically egg on a string appearance. And egg on a string appearance is typically seen in children who have a transposition of the great artery. So the correct answer is TGA. What further supports our diagnosis is that this child has a cyanotic disorder. And a cyanotic disorder or a cyanotic congenital heart disease means TGA. Although TOF, tricuspid atresia, hypoplastic, the other options also are cyanotic, TGA is also cyanotic. So sign of 3, coarctation of aorta, boot-shaped heart, tetralogy of fillet, egg-on string appearance is box-shaped heart is Epstein's anomaly, egg-on string appearance is a transposition of the great arteries, and snowman's heart is TAPVR. So again, what I'm requesting you, please learn the art of identifying X-rays because they will be asked in the exams, and specifically these X-rays where you have typical type of appearances are frequently asked in the exam. So be very, very familiar with these X-rays. So this is an egg on string appearance, and as most of you have correctly identified, it's a TGA. Coming to question number 10. An infant with a history of cyanosis, poor feeding after birth and progressively increasing tachypnea is evaluated. His X-ray shows oligemic lung fields. Oligemic lung fields means pulmonary blood flow is decreased. Oligemic lung fields means pulmonary blood flow is decreased. The second clue is his ECG reveals that there is a left ventricular hypertrophy. So now you have a decrease in the pulmonary flow and there is a left ventricle hypertrophy. So there is a decrease in the pulmonary flow and there is a left ventricle hypertrophy. He is asking which of these congenital heart diseases in the child most likely suffering from. So let me see what is your correct answer. The child has a cyanotic heart disease. So first clue, the child has a cyanotic heart disease. Second clue, the child has reduced pulmonary blood flow because they are saying he has oligemic lung fields. And third clue, he is having a left ventricle hypertrophy. And I see most of you have given the answer as B, which again means that possibly what I had taught in my class, the classification, you are still not familiar with that. Those who are answering it as B, okay, let me again go back to that classification of congenital heart disease. I told congenital heart diseases are divided up into acyanotic heart diseases and cyanotic heart diseases. Acyanotic heart diseases are further divided up into diseases which are associated with left to right shunts and diseases which are associated with ventricle obstructions. For a moment, forget acyanotic heart disease because our question is not on an acyanotic heart disease but on a cyanotic heart disease. Cyanotic heart disease, I had very clearly mentioned in my classes that cyanotic heart diseases are divided into those with decreased pulmonary flow and those with increased pulmonary flow. Decreased pulmonary flow is also referred to as pulmonary oligemia, and increased pulmonary flow is also referred to as a pulmonary plethora. So in our question it is written pulmonary oligemic lung fields, which means the pulmonary blood flow is decreased. Now, decreased pulmonary flow, I told in my classes, is further divided up into those with RVH and those with LVH. Now, under RVH, I had mentioned TOF, but under LVH, I had mentioned tricuspid atresia. While under increased pulmonary flow, I had mentioned TGA, TAPVR, truncus arteriosus and a hypoplastic left heart syndrome. So it's very simple. Our patient has a pulmonary oligemia, that means a decreased pulmonary flow. Those who are answering decreased pulmonary flow and answer is TOF are correct. But please remember, decreased pulmonary flow with RVH is TOF. Our patient has a decreased pulmonary flow with LVH, not RVH. Please see the question carefully. They are saying oligemic lung fields, but ECG reveals a left ventricle hypertrophy, not a right ventricle hypertrophy. Those who are saying TOF is correct, then they would have given right ventricle hypertrophy. Our patient has a left ventricle hypertrophy. And for a left ventricle hypertrophy, the answer should be tricuspid atresia. Tricuspid atresia. Therefore, the correct answer to tricuspid atresia. Have you all understood congenital heart diseases? Have you all understood congenital heart diseases classification at least? Please understand, in your FMG exams, it is highly unlikely you will be asked in depth about any congenital heart disease. At least the superficial classification you should know. Which are acyanotic, which are cyanotic, what is oligemia, what is plethora, What are the names given to different syndromes? Which presents with RVH, which presents with LVH? Simple things. Please be very, very familiar with just simple things about congenital heart diseases. So here the answer is very good. So those who are saying yes, very good. So here the answer is tricuspid atresia. The answer is not TOF but tricuspid atresia. Now coming to question number 11, which many of you have already started answering, which is very good. Which of these is the last milestone to appear in the child? So in language milestones, I've already told jargons appears at 15 months. I've already given the answer previously also. Babbling normally appears at around 6 months. Sentences normally appears at 2 years, so 24 months. And cooing, I told you, often appear at 1 month. Cooing 1 month, vocalizing 3 months, babbling 6 months, jargons 15 months, sentences 2 years, 24 months. So they are asking which of these is the last milestone to appear. So now it's very clear in front of you. The last milestone to appear in the child is sentences. I don't think there should be any question answering this question. Please remember milestones thoroughly. Just the milestone that I have given you should be good enough for your exams unless and until they ask something out of the world. Most of the milestones that I have given in my notes, I think should be sufficient for your exams. No one can predict exactly what question will come, but going by the trend in the last few years, in whatever I've taught in my classes, the milestones that I've taught in my classes, and if suppose there is once or twice a question that comes in where I have not taught that milestone in my class, in the next session onwards, I add that milestone also. For example, stranger anxiety. I did not used to teach stranger anxiety, but in the FMG exam, I think last FMG exam or last to last FMG exam, they asked stranger anxiety. So henceforth, I've added stranger anxiety also in my class, notes. So just try not to go too much depth into the milestones. Just be superficial, otherwise you'll end up confusing if you try to go too deep into different milestones and refer multiple books. Then you'll get confused because many books, they give different answers to the milestones. Coming now to question number 12. A mother of a 2.1 kg newborn, the child is otherwise healthy and hemodynamically stable. The mother wants your advice on the best way to keep the newborn baby warm. So this baby is a 2.1 kg baby. That means the baby is a low birth weight babies. All babies who are less than 2.5 kgs will be called as low birth weight babies. All babies who are less than 1.5 kgs will be called as very low birth weight babies. And all babies less than 1 kgs will be classified as extremely low birth weight babies. So this baby is a low birth weight baby. And the mother is asking your advice how to keep the baby warm. Which of these methods is the standard of care for keeping such newborn babies, which means such low birth weight newborn babies warm? And as most of you have correctly answered, it is kangaroo mother care. Kangaroo mother care actually is the standard of care for low birth weight babies, but can also be used for keeping preterm babies warm. So kangaroo mother care is a standard of care, best way to keep low birth weight babies warm, but it can also be used for keeping preterm babies warm. And there are a triad of things that come under kangaroo mother care. First, as I've told you, is a prolonged skin to skin contact. Second is early initiation of exclusive breastfeeding. And the third is early discharge of the baby when the baby is stable. Prolonged skin to skin contact, early initiation of exclusive breastfeeding, and early discharge of the child from the hospital when the child is stable. It is usually recommended for low birth weight babies and preterm babies, and is usually recommended, because I'm saying for low birth weight and preterm babies, so usually is recommended for babies who are less than 2.5 kgs, but obviously should be more than 1.8 kgs. That is the criteria. The child should not be below 1.8 kg. If the child is below 1.8 kg, then that ideally does not fit into the criteria of a kangaroo mother care. The child should be low birth weight, less than 2.5, but above 1.8, and the child should be preterm. That means the child should be born less than 37 weeks. So till what time should kangaroo mother care be given? So because it is for less than 2.5 and less than 37 weeks, so after birth, the moment the child's weight becomes more than 2.5 or the child's post-gestational period crosses 37 weeks. So suppose the child was born at 34 weeks, so 3 weeks more kangaroo mother care is given. Post-gestational period once crosses 37 weeks, then kangaroo mother care can be stopped. It is recommended for all babies who are less than 2.5 but more than 1.8, or babies who are preterm, and the babies who are hemodynamically stable. I think if any question is asked on kangaroo mother care, among these things that I have written, these are the only questions that can be made on kangaroo mother care. Very important topic again for your exams. So again and again I am saying, no one can predict exactly what questions will be asked, but going by the trend, whatever topics I have chosen, the questions from the topics that I have chosen, please take those topics. I do not need to tell you. You should now be intelligent enough to take these topics as the most important topics for pediatrics for your FMG exam, and be very well prepared from at least these topics. I would always like you to be prepared from the whole of pediatrics, but that is not practically possible, at least at the FMG level. So what I would recommend is be well prepared at least from these topics for your upcoming FMG exam. Now coming to question number 13. A 3-year-old girl developed an obstructive hydrocephalus. So I have told that hydrocephalus can be of two types in children. One is when there is obstruction inside the ventricles, when the hydrocephalus is called as an obstructive or a non-communicating hydrocephalus, and this is the most important type of hydrocephalus that you see in children. The other type of hydrocephalus is a hydrocephalus which develops not because of obstruction inside the ventricles, but because of impaired absorption of the CSF through the subarachnoid villi. That type of hydrocephalus is called as non-obstructive or a communicating hydrocephalus. So hydrocephalus of two types: obstructive, non-obstructive. Obstructive is also called as non-communicating. Non-obstructive is also called as communicating. Obstructive hydrocephalus is again divided into two types. Either it can be a congenital obstruction, or it can be an acquired obstruction after birth. Some congenital problems which can be associated with obstructive hydrocephalus may include problems such as a congenital aqueductal stenosis. That's the most common cause of obstructive hydrocephalus, congenital aqueductal stenosis. Other than this, there are sometimes syndromes such as Arnold-Chiari malformation, Dandy-Walker syndrome. They can also be associated with hydrocephalus, obstructive hydrocephalus. Now, acquired causes of obstructive hydrocephalus means there are some problems which develop after birth in the child. So the child was not having a hydrocephalus from birth, but there were some problems that developed after birth because of which the child developed an obstruction in the ventricles. And most of those problems are usually a result of infections. In neonates, for example, a neonatal meningitis can result in an obstruction inside the ventricles. Now, two most important childhood infections which can be associated with obstructive hydrocephalus are mumps and toxoplasmosis. So remember, the most common viral infection associated with hydrocephalus is mumps, and most common parasitic infection associated with hydrocephalus in children is toxoplasmosis. So in this case, since he's saying the child was suffering from a viral infection. So viral infection means now you have to think which viral infection is the most common. I just now told you it is mumps. Most important viral infection associated with hydrocephalus. Some of you have given erythema infectiosum. No, erythema infectiosum does not very commonly cause an obstructive hydrocephalus. No. Erythema infectiosum is more commonly a problem which is associated with a slap cheek appearance on the face. Parvovirus B19 infection. It's not a problem associated more commonly with this condition. Erythema infectiosum leads to slap cheek appearance. It often leads to rashes inside the palms and the soles, which is also called as PPGSS, papillopurpuric glove and sock syndrome. Papillopurpuric glove and sock syndrome. That can also occur as a complication of erythema infectiosum. Erythema infectiosum can also lead to myocarditis. It can be a cause of hydrops fetalis. It can be a cause of aplastic crisis. Parvovirus B19, not erythema infectiosum, sorry. These are problems of parvovirus B19. Parvovirus B19 can cause erythema infectiosum, but parvovirus B19 can also cause other problems in children, such as rashes in the hands and feet, which are also called as papillary purpuric glove and sock syndrome. Glove and sock because rashes occur in the hands and feet. Then parvovirus B19 infection children can also lead to myocarditis, can also lead to aplastic crisis. Parvovirus B19 infection in pregnancy can also lead to hydrops fetalis. In NEET PG, they have asked this multiple times, problems of parvovirus B19 infection. Now, I do not teach infections in my classes, so I have not touched erythema infectiosum as such, but it's an important topic which can be asked in the exams. Not erythema infectiosum as such, but parvovirus B19 infections. But usually hydrocephalus is not a consequence of parvovirus B19 infection. Roseola infantum, more commonly human herpes virus, 6 and 7, more commonly. So as the name suggests, Roseola infantum, this is a problem most commonly which happens in children who are infants, less than 1 year. High grade fever, child has rashes, and the best identifying part of Roseola infantum is that in Roseola infantum, rashes appear only after fever disappears. So in NEET PG, they often ask this question, fever disappears, rash appears. So fever disappears and rash appears. This is typically seen in Roseola infantum. Sir, cooing is in 3 months, you told in notebook. Yeah, I'm really sorry. I have been telling cooing. I'm really sorry. Yes, please just correct it. Vocalizing is 1 month. I'm really sorry. Vocalizing is 1 month. Cooing is 3 months. I'm really sorry. Actually speaking, these two are very interrelated terms, but thank you for, Manish, thank you for confirming this. I'm really sorry, 2-3 places if I have spoken this, please just correct it. Vocalizing is 1 month, cooing is 3 months. Please correct it. I'm really sorry for this and please correct it. So, wherever I mentioned vocalizing as 3 months and cooing as 1 month, please just correct it. Vocalizing is 1 month, cooing is 3 months. Although they again overlap very frequently. But please correct this. I'm really sorry. And thank you, Manish, for correcting this. Now, coming back to our topic. So, erythema infectiosum is related to parvovirus B19 infection. Roseola infantum is associated with human herpes virus infection. And hand, foot and mouth disease again is a disease which is limited to problems in, as the name suggests, hands and in the mouth and sometimes in the feet. So painful ulcers which can develop in the mouth, painful ulcers which can develop in the hands and feet. But again, it is not related as such to hydrocephalus. So hydrocephalus, once again, obstructive, non-obstructive. Obstructive again is predominantly divided up into obstructive which can be congenital, obstructive which can be acquired. Obstructive congenital can include congenital aqueductal stenosis, syndromes such as Arnold-Chiari, Dandy-Walker, and then non-obstructive and obstructive which are acquired can be because of infections. The most common viral infection is mumps, and the most common parasitic infection is toxoplasmosis. Okay? Any other thing that you want to ask? Mumps, pneumonic. I have not understood what is meant by mnemonic, mumps, pneumonic. Anyway, vocalizing and cooing you have all corrected. So vocalizing 1 month, cooing 3 months. That is what I teach also in my classes. But again, I'm saying it often overlaps. In many books I've seen cooing also they have mentioned as 1 to 3 months. But please correct it, and I hope you have all corrected. I'm really sorry. Wherever 1 or 2 places I mentioned it the other way, please correct it. In many books they mention different ages for different milestones. Mumps mnemonic, I have still not understood Divas what he is trying to say. Mumps mnemonic. I do not teach mumps, so I have not given any mnemonics. Mumps is basically a type of parotitis. So there is enlargement of the parotid glands, and the mumps infection typically presents with a large swelling which is present in the area around the parotid gland, and this can actually displace the ear lobes also. And it's quite a common infection that is seen in children. So here also you 11th question you correct it as 3 months. Right, here also you correct it as 3 months. Anywhere else if I mentioned cooing as 1 month, please correct it as 3 months. Vocalizing as 1 month. Sorted. Can I move to the next question? Any other question you want to ask till here? Okay, let us come now to question number 14. A term infant after birth develops tremors, dystonia, progressive seizures, and a persistent rigidity. The child was diagnosed with kernicterus. Which of these cerebral palsies is the child most likely to develop as a result of kernicterus? So when I say cerebral palsies, mumps, how to remember? I don't know any mnemonic of mumps. Primarily mumps, the only way to remember is parotitis. I don't think there is a very specific prodromal phase for mumps for you to remember anything. For example, in measles, we have a very specific prodrome which includes child having 3 C's, cough, coryza, conjunctivitis. So those 3 C's are the characteristic prodrome of measles. But for mumps, I don't think we have a very typical prodrome. So for mumps, mainly in my NEET PG classes, I normally teach it as primarily parotitis. Coming back to a question here, a term infant after birth develops tremors, dystonia, progressive seizures, persistent rigidity, diagnosed with kernicterus. Now, what is cerebral palsy? Okay, very sad to see that again the answer given by most of the questions, at least I would have expected that students who have attended my classes would have given the answer to this question correctly. But very sad again because answer given by most of you is wrong. See, I have told what is cerebral palsy. Cerebral palsy is a non-progressive neuromotor disorder which is associated, non-progressive neuromotor disorder which is associated with injury to the brain very early in life. So at the time when the brain is developing very fast, which is in the prenatal period or just after birth, any injury that develops to the brain, which can occur because of prematurity, the child being born low birth weight, the child having a hypoxic episode, the child having a hypoxic ischemic episode, the child having a meningitis, the child having a kernicterus, any injury that develops in the brain can result in the child developing a long-lasting effect, which can be persistent throughout life. That CNS disorder is called as cerebral palsy. Now, I told cerebral palsies are categorized into 3 categories, 4 categories are there in children. One is spastic, the second is dyskinetic or sometimes called as extrapyramidal. The third is ataxic, and the fourth is mixed. Now, which part of the brain are primarily damaged, which leads to these types of cerebral palsy? So, as I told you, For spastic, primarily it's the cerebral cortex that is damaged, which leads to a spastic cerebral palsy. And depending upon which part of the body is spastic, you may have a spastic hemiplegia, a spastic diplegia, or a spastic quadriplegia. Dyskinetic or extrapyramidal palsies are palsies which primarily develop as a result of damage to the basal ganglia. So while spastic cerebral palsies are primarily a result of damage to the cerebral cortex, dyskinetic cerebral palsies, here there is no spasticity, here there is dystonic movements, and dystonic movements primarily develop because of damage to the basal ganglia. Ataxic is primarily due to the damage to the cerebellum. So ataxic cerebral palsy is developed when cerebellar damage occurs, and mixed obviously is mixed features of all of these. So the first clue to which type of cerebral palsy will develop should be from which part of the brain will be affected. So as I said, spastic cerebral palsy is because of damage to the cerebral cortex. Extrapyramidal cerebral palsy is because of damage to the basal ganglia. Ataxic cerebral palsy is because of damage to the cerebellum, and mixed cerebral palsy is mixed features. Now, do you want to revise the answer to this question? Kernicterus has occurred. Kernicterus is bilirubin entering into the brain. Which part of the brain is predominantly damaged when kernicterus occurs? So, kernicterus is a chronic sequelae of brain damage as a result of bilirubin entering or crossing the blood-brain barrier. So now do you want to change your answer? Yes, the answer should not be spastic palsy. The answer should be extrapyramidal palsy, because no, not half paralysis. Half paralysis, full paralysis, spastic paralysis is always because of cerebral cortex damage. Kernicterus is bilirubin damage, and this always damages the basal ganglia. Which part of the brain is primarily damaged by bilirubin? So when bilirubin enters the brain, it primarily damages the basal ganglia. And if basal ganglia is damaged, which type of cerebral palsy? Yes, so you will develop the child will develop a extrapyramidal cerebral palsy. Please remember this. Have you all understood the concept? To answer any question on cerebral palsy, you should first know which part of the brain will damage. Because when you know which part of the brain is damaged, only then you will come to know what type of cerebral palsy is likely to develop. So if cerebral cortex is damaged, spastic cerebral palsy will develop. If basal ganglia is damaged, dyskinetic or extrapyramidal cerebral palsy will develop. If cerebellum is damaged, ataxic cerebral palsy is damaged. And if there are different parts of the brain damaged at the same time, then mixed cerebral palsy will develop. Because kernicterus is known to cause damage to the basal ganglia, it will not lead to ataxic or spastic palsy, because ataxic is due to cerebellar damage and bilirubin damages the basal ganglia primarily. If you remember, I told you in preterms in my classes, I told you preterms develop a type of ischemic brain damage, which is called as periventricular leukomalacia, PVL. That periventricular leukomalacia develops around the ventricle, so it is cerebral cortex damage. And when cerebral cortex damages, what type of cerebral palsy will develop? Spastic cerebral palsy. So periventricular leukomalacia is associated with spastic cerebral palsy, and specifically spastic cerebral palsy where the lower limbs are affected to a greater extent than the upper limbs. So spastic diplegia. But kernicterus will not develop the cerebral cortex mainly. It will mainly develop damage the basal ganglia. And therefore the most likely type of cerebral palsy that develops after kernicterus is extrapyramidal cerebral palsy. While most of you have given the correct answer, there is still one answer which is C, which again does not make sense, because I've just now told you cerebral cortex damage will only lead to spastic palsy, and usually cerebral cortex damage does not occur with kernicterus. Kernicterus usually causes a basal ganglia damage primarily. So I hope now you have understood the question and the concept which was related to this question. Cystic fibrosis is a disorder emerging as an increasing cause of concern, including in children. It is primarily caused by a gene. So there is a mutation in the gene that codes for the CFTR protein. So rather than saying it's primarily caused by a gene, it is primarily caused a mutation in the gene that codes for the CFTR protein, cystic fibrosis transmembrane regulatory protein. Now the question is, this gene is located on which chromosome? So what is your answer? Most of you are saying again 11. 11, 11, 11. No, 11 is not the correct answer. 11 is not the correct answer. CFTR mutation involves mutation of the cystic fibrosis transmembrane regulatory protein. More than 1,500 mutations. More than 1,500 mutations of CFTR protein are known, and this is mainly a protein located on chromosome. Yes, 7. Very good, 7. So now I'm getting the correct answer. Answer is chromosome 7. So cystic fibrosis mainly results from mutation in the CFTR protein, which is most commonly located on chromosome 7. Which is the most common mutation? Let me see if you can tell me which is the most common mutation which causes cystic fibrosis. Let me see if you can answer this question. What is the most common mutation that causes cystic fibrosis? So answer here is 7. Chromosome is affected. Which is the most common mutation? Yes, 508, but more specific. More specific. Which is that most common mutation that causes cystic fibrosis? CFTR is the name of the protein. What is the most common mutation? So I said more than 1,500 mutations. More than 1,500 mutations that cause cystic fibrosis. Now question is, which is the most common among them which causes cystic fibrosis? Yes, very good. So it is delta F508 mutation. So the most common mutation that leads to cystic fibrosis is delta F508. It is deletion of phenylalanine from position 508 of chromosome 7. It is deletion of phenylalanine from position 508 on chromosome 7. This is the most common. Very good. So now I'm getting the correct answer. Most common mutation that causes cystic fibrosis is deletion of gene which is located on deletion of the protein, which is deletion of the gene which codes for the CFTR protein. And in this deletion, what is mainly deleted? It is the phenylalanine residue. So F stands for phenylalanine word, although phenylalanine starts with P, but it is in reference to the phenylalanine word F. So deletion of the phenylalanine from position 508 on chromosome 7. That's the most common mutation that causes cystic fibrosis. Then I've already told that cystic fibrosis is known to result in obstruction to different ducts of the body. Let me ask another question. Which is the only duct in the body which does not get obstructed in cystic fibrosis? Which is the only duct in the body? So airways get blocked, pancreatic ducts get blocked, bile ducts get blocked, intestines get blocked. Remember meconium ileus, which is the only duct in the body which is not blocked in cystic fibrosis, not obstructed in cystic fibrosis. Let me see the answer. Which is the only duct in the body which is not obstructed in cystic fibrosis. The only duct in the body which is not obstructed in cystic fibrosis. No, it is not vas deferens. We are talking about children, so mostly we will not talk about. Yes, sweat duct is usually not obstructed. Very good. So sweat duct is usually not obstructed in cystic fibrosis. Again, something that I have told in my classes. This is a very important NEET PG question. Which duct is usually not blocked in cystic fibrosis? Sweat duct is not blocked. Most of the other ducts get blocked. So they can be obstructive airway diseases, there can be thick phlegm, there can be persistent productive cough in children, there can be cholestasis in children leading to an obstructive jaundice, there can be pancreatic duct obstructions leading to indigestion of proteins, fat malabsorptions occurs, the stools have foul smell because they are full of fat, there is steatorrhea, malabsorptions, low weight, then meconium ileus in newborns, distal intestinal obstructions in older children. All of these problems can occur. I'm talking mainly about problems in children. I'm not talking about gonadal problems which occur in older people, but in children. But one duct which is not blocked is the sweat duct. And that is why sweat chloride test is the most commonly used test for diagnosing cystic fibrosis. I don't think they will ever ask these questions because this is more commonly a question related to NEET PG. Usually symptomatic treatment is given in cystic fibrosis, but now there are some gene modifying therapies which are being used for cystic fibrosis management in selected cases, because these can only reverse selected mutations. So these gene modifying therapies, for example, ivacaftor, lumacaftor, these are some disease modifying therapies which are being used in selected cases because they can only reverse certain mutations in cystic fibrosis. It is not more than 60 ml, it is more than 60 milliequivalents per liter. So sweat chloride more than 60 milliequivalents per liter, not 60 ml. Not vacacaftor, it is ivacaftor, lumacaftor. These are some of the gene modifying therapies which are being used. There are some which are under evaluation also, but more commonly these are the options that are being used. But please remember, these are the drugs that are still not given for reversing all mutations. They can only reverse selective mutations, and I just now told you more than 1,500 mutations can cause cystic fibrosis. So before you give these drugs to a child of cystic fibrosis, you have to first confirm that the drug reverses only select mutations. So is that mutation a cause of cystic fibrosis? So ideally a karyotyping is properly karyotyping, and evaluation is required before you are able to confirm that yes, this is the mutation that has caused cystic fibrosis in the child, which can be reversed by this drug. Otherwise, don't give that drug. Coming to question number 16, all of the following are diagnostic criteria for severe acute malnutrition in children except, yes, ivacaftor also. Very good, ivacaftor also. So all of the following are diagnostic criteria for severe acute malnutrition in children except, so I have again and again told in my classes the term SAM, and the criteria for SAM I have told bilateral pedal edema, weight for height below -3 Z scores, and mid-arm circumference less than 11.5 centimeters. So in SAM, the criteria used are bilateral pedal edema, weight for height less than -3 Z scores, and mid-arm circumference less than 11.5 centimeters. So yes, this is a pretty simple question. Weight for age, you have all answered correctly, although there is one answer given as B and one answer C also. These are criteria. He's asking which is not a criteria. When they say except, it means which is not a criteria. So pedal edema is a criteria, weight for height less than -3 Z scores a criteria, mid-arm circumference less than 11.5 centimeters a criteria, and in young children, visible severe wasting of muscles is another criteria, but weight for age usually is not taken as a criteria for confirming the child as severe acute malnutrition. So most of you have given the correct answer, and the correct answer is weight for age. Moving forward, one more question which I have on severe acute malnutrition. A child with severe acute malnutrition is admitted in the ward. All the following can be started in the child within the first week of treatment. So when a child of severe acute malnutrition comes to you and is specially hospitalized, I have told you a mnemonic which are the problems seen in these children. And this mnemonic is given, this mnemonic is shielded CSF. So the child has sugar deficiency, hypoglycemia. The child has hypothermia, the child has infections, the child has electrolyte disorders, the child has dehydration, the child has deficiency of micronutrients, the child has to be given proper calories, cautious feeding, but ultimately the calories need to be increased, so catch up growth. Then the child requires a sensory stimulation during the play period. Child should be in contact with the mother, so the child should be provided a sensory environment to grow. And finally, F means follow-up after discharge of the child. All of this I've told in my classes. Now the question is, when the child is having deficiency of micronutrients, several micronutrients need to be added in the diet, which includes copper can be added, zinc should be added, iron should be added, folic acid, which is requires to be corrected, vitamin A requires to be given, especially in children who have vitamin A deficiency. But the point is that iron should not be given, which I have again and again specified, in the first week of treatment. And you all have given, nearly all have given a correct answer. Iron should not be given in the first week of treatment. Reason is that iron can promote infections. And because infections are predominant cause of morbidity also, hospitalizations also, in some cases mortality also, in a child of severe acute malnutrition, you cannot compromise on infections. For that, you are giving antibiotics within the first week of management. So on one hand, you are giving antibiotics for managing infections. And on the other hand, you are starting the child on iron, which will compromise the effects. It will promote more infections to grow. Because these iron is actually the coenzyme for a number of bacterial, viral, fungal enzymes. So it actually helps the microbial growth in children and adults. So never compromise on infection part by giving iron. So only supplement iron when infections are treated. Other than this, antibiotics can be given in the first week of treatment. IV fluid for dehydration correction should be done either by ringalactate in 5% dextrose or N/2 in 5% dextrose. Rizomal can be given. But iron should be started only after the second week, not in the first week of management. So hypoglycemia needs to be treated either by intravenous or by giving oral glucose sucrose. Then hypothermia needs to be treated. Then infections need to be treated by giving antibiotics. Electrolyte disorders, which electrolyte disorders I have told in my classes occur in children with malnutrition. So there will be relatively hypernatremia. So give low sodium in these children. Don't give high sodium. There will be hypokalemia. So give high potassium in these children. And there might be also hypomagnesemia, low magnesium. So magnesium also needs to be added. In addition to this, the child will also have dehydration. For dehydration, I've told in my classes that you need to manage dehydration mostly with oral fluids unless and until the child is in shock. Unless and until the child is in shock. Oral dehydration can be managed by giving Rizomal or a modified form of ORS, which is diluted, so that you reduce down the sodium content and add more potassium content, glucose content in the solution. And then you have intravenous fluid that can be given in cases of shock. Intravenous fluid, I've told, will either be ringalactate in 5% dextrose or will be N/2 in 5% dextrose. Apart from this, calculating the deficiencies and giving micronutrients for supplementation, which, as I've told, iron should not be given the first week. Coming to calories, start with low calories and gradually increase the calories. So we start with 75 kilocalories per kg per day, gradually increase it upwards and reach 150 to 200 kilocalories per kg per day. But that should be gradual, because if you start calories very high early in the malnutrition process, you are likely to result in complications in the child. And I've told you that those complications can result in hypophosphatemia, hypokalemia. What is the name of that complication? When you give too much of high calories early during the treatment phase of malnutrition. I've told in my classes, what is that complication called? Let me see if you remember. If you start giving very high calories too early in malnutrition, what is that complication which can lead to hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency? What is that complication called? I've told in my classes. What is that complication called? Very good. It is called as the refeeding syndrome. Very good. That complication is called as the refeeding syndrome. Very good. So what are the features of refeeding syndrome? So the features of refeeding syndrome are hypophosphatemia, hypokalemia. Very good. Hypophosphatemia, hypokalemia, hypomagnesemia. Hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency. That is why you need to start the child with low calories and gradually according to the tolerance of the child. So according to the way the child is responding, then you can gradually increase the calories as per the tolerance. But do not overload the child on in calories. That is why we say that C stands for start cautious feeding and then gradually increase the calories for a catch-up growth. Then S stands for sensory environment. So child needs to be, the treatment needs to be started in a sensory environment wherein the child is in contact with the mother, the child has a playful environment along it. Actually speaking, all things can help in making the child grow, overcome the problems that the child is currently having. But unless and until you give a sensory environment to the child, which improve his sensory stimulations, there will not be improvement in the child. And F stands finally for the follow-up after discharge. So all of this again I have discussed at length in my classes. Coming now to question number 18, which again is something related to short stature, but this is more importantly a type of question on proportion and disproportion. So they have written a 3-year-old child with short stature has an upper segment to lower segment ratio of 1.3:1. So I have told in my classes the ratio of upper segment to lower segment at birth is 1.7:1. By 1 year it becomes about 1.6:1. By 3 years it becomes 1.3:1. By 6 years it becomes 1.1:1. And by 7 years to 10 years it becomes 1:1. So birth it is 1.7:1. 1 year it is 1.6:1, 3 years it is 1.3:1, 6 years it is 1.1:1, and 7 to 10 years is 1:1. Now they are asking the question that the child has an age of 3 years and the child has an upper segment to lower segment ratio of 1.3:1. So this is there in front of you. So the child is 3 years and has an upper segment to lower segment ratio of 1.3:1. Does this child have a proportionate or a disproportionate short stature? He will have a disproportionate short stature only when his body proportion is not matching with this normal, which means at birth 1.7:1 is not there, at 1 year 1.6:1 is not there, at 3 years 1.3:1 is not there, at 6 years 1.1:1 is not there, and 7 to 10 years upper segment to lower segment ratio. So as you correctly see that at 3 years his upper segment to lower segment ratio is matching with what should be for age. That is why this child has a proportionate short stature. Very good. So therefore this child has a proportionate short stature. He doesn't have a disproportionate short stature. So proportionate, disproportionate, disproportionate with long trunk, short extremities, infantile disproportion, and disproportionate with short trunk and long extremities, advanced disproportion. Coming to question number 19, an infant born to a diabetic mother is most likely expected to have a weight of. Now this again is checking whether you are aware of the complications that can be seen in infants of diabetic mothers. So most infants who are born to diabetic mothers are expected to have the complication of SGA, AGA or LGA. Which of them is the correct answer? Which is very commonly seen in infants of diabetic mothers? SGA, AGA or LGA? Yes, most of these children have LGA, large for gestational age. And as I told you, large for gestational means overweight. Very good. More than the 90th percentile. So the correct answer should be more than 90th percentile. Let me tell you, in some cases, children who are born to diabetic mothers may develop, because diabetes is ultimately a vascular disorder. affects the blood vessels. So in some cases of diabetes in mothers, the placental vessels can be affected. And when placental vessels can be affected, placental dysfunction affected, it can lead to the development of an IUGR, SGA type babies. So sometimes an IUGR can also result in infants of diabetic mothers, but that is basically not the point. The point that I'm trying to say is most babies who are born to diabetic mothers are large size babies. Small babies are babies who are less than 10th percentile. We call them as small for gestation age babies. More than 98th percentile, babies who are large for gestation age babies. And AGA are babies who are between 10 to 98th percentile. So most babies who are born to infants of diabetic mothers are, as you have correctly pointed out, are large for gestation age babies. Coming now to question number 20. Identify the wrong statement about congenital diabetes. This is again a very important question. Very important question, which is asked again and again in the exams. In fact, last time also in FMGE, you had the question on congenital diaphragmatic hernia. So again, a very important topic. I do not need to tell you. You should know that this is a very important topic for your exams. Congenital diaphragmatic hernia. So congenital diaphragmatic hernia is basically herniation of the abdominal contents in the child up into the chest cavity, wherein they start obstructing the space inside the chest. So the lungs in many cases in the fetus are not able to grow, resulting in pulmonary hyperplasia. There might not be time for the lungs to expand and for the pulmonary pressures to fall after birth. If you remember, I told you, fetal pulmonary pressures are very high, physiological pulmonary hypertension. After birth, pulmonary pressures should fall and the lungs expand, fill up with air. Because in these cases, the lungs do not fill up with air. So there can be persistence of pulmonary hypertension even after birth. And that's one of the very important causes. Pulmonary hyperplasia and resulting pulmonary hypertension persisting is one of the very important causes of death in children with diaphragmatic hernias. Now, most of these hernias occur through a foramen on the left side, which is basically the Bogdelic area. Only in some cases, the herniation is on the right side. So, as I've said, most cases the herniation is on the left side, not on the right side. So, they are saying identify the wrong statement. So, according to me, A should be the wrong statement. Most hernias are not on the right side, Morgagni hernias. No, most hernias are on the left side, which are called as Bogdelic hernias. Because here the hernia is through the foramen of Bogdelic. Now, because most of these things come up into the chest, the abdomen is empty and there is a scaphoid abdomen. So, there is a boat-shaped abdomen. So, they are associated with a boat-shaped abdomen. Apart from a boat-shaped abdomen, when you start treatment of these babies, never start with bag and mask ventilation. So, the point C is also correct. It's not a wrong statement. Bag and mask ventilation is contraindicated because if you do bag and mask ventilation, you will be pushing air into the stomach. And the stomach, remember, right now is not in the abdomen. It is in the chest. So, you will be compromising the chest space even further. And when you are contracting, when you are actually having too much of pumping that is being given through the ambu bag, you will inflate the stomach more and more, which is in the chest cavity. So, therefore, one of the contraindications of bag and mask ventilation is a congenital diaphragmatic hernia. Now, when the contents of the abdomen have entered into the chest cavity, they will press the esophagus of the fetus. And when the esophagus of the fetus will be compressed, the fetus, which is surrounded by the amniotic fluid, will not be able to swallow the amniotic fluid. So, although the urine output is contributing to the amniotic fluid cannot be swallowed because the esophagus of the fetus is being compressed, which leads to the complication of polyhydramnios. So, polyhydramnios is a pregnancy complication occurs again in congenital diaphragmatic hernia. So, polyhydramnios occurs, bag and mask ventilation, yes, this is true. Scaphoid abdomen is true, but he is not asking the true statement, he is asking which is the wrong statement, and therefore A should be the correct answer. Yes, Morgagni's enteromedial and posterolateral is Pogdalic. So diaphragmatic hernias, all of you are now confident. I think mostly with the question comes, it will be from here. The main treatment of diaphragmatic hernias, congenital diaphragmatic hernias in newborn babies is start intubation. Start with intubation, not with bag and mask ventilation. Start with intubation, then move to nasogastric tube insertion, then ventilation, and finally take the child for surgery. Very good. Let us now come to question number 21. Question number 21 says, increase in length in the first year of life in children is what percentage of the length at birth? This is a slightly tricky question. They are asking increase in length in the first year of life in children is what percentage of the length at birth? So simple calculation, the length at birth is usually 50 centimeters. 1 year it becomes 75 centimeters. Now can you answer the question? They are asking increase in length in the first year of life is what percentage of the length at birth? So the increase that occurs in the first year is 25 centimeters. Increase that occurs in the first year is 25 centimeters because the length at birth is 50 and the length at 1 year is 75. So increase in the first year is 25 centimeter. Now this 25 centimeter is what percentage of the length at birth? Yes, 50%. Because the length at birth is 50 centimeters and increase in length in the first year is 25 centimeter. So increase in length in the first year of life is 50% of the length at birth. Correct. So most of you are given a correct answer. 50%. Very good. Most of you have given correctly the answer. There is one answer which is 75%, which is wrong. I just now told you the increase in length that has occurred in the first year is 25 centimeters. The length at birth is 50 centimeters. So increase in length in the first year of life is 50% of the length at birth. Coming to question number 22. A newborn on day 3 of life develops these type of yellowish pustules which are surrounded by an irregular erythematous base. And this appearance has often been called by doctors as a flea-bitten appearance, as if a flea has bitten on the trunk of the child. This is very commonly seen in newborn babies, especially in the first week after birth. The baby otherwise is healthy, taking feeds, does not appear to be sick. So he is otherwise normal. Only thing that this child appears to be having is rashes, mainly present on the trunk, very few rashes on the face, but mainly present on the trunk. So more of a centripetal type of an appearance. What is this appearance called? Let me see if you can answer. What is this appearance in the newborn called? What are these rashes? These rashes are also called as the most common erythematous rash of the newborn period. What are these rashes called? So what are these erythematous rashes? Very good. So these rashes are called as erythema toxicum. Sometimes also called as erythema toxicum neonatorum. So these rashes are called as erythema toxicum. They are also sometimes called as erythema toxicum neonatorum, and most of these rashes are made up of eosinophils. So your answer is correct. Most of these rashes are made up of eosinophils. These are the most common rashes that are seen in the neonatal period. Most of these rashes appear in the first week of life, but they will never appear on the first day of life. So any rash in a newborn appearing on the first day is unlikely to be an erythema toxicum. So they may appear on day 2 or day 3, spread over the trunk, very little rashes present over the face or over the palms and soles. Most of the rashes will be on the trunk. Some rashes may be on the extremities, but not in the palms and soles. And these rashes disappear usually by the end of the first week. The child otherwise remains healthy, is taking feeds well, and these rashes appear to be an allergic response to some allergens which are still not known. So the cause still remains unknown as such, but why do we feel that these appear to be an allergic response? Because when the scrapings from these rashes are seen under the microscope, they are seen to be filled up with eosinophils. That is what leads us to believe that these are allergic rashes. They are also called as erythema toxicum or erythema toxicum neonatorum. So you have currently identified. Question number 23 says a neonate with intractable seizures despite the use of multiple anti-epileptic drugs can be treated with one of these vitamins to abort seizures. So which of these neonatal vitamins can be given to treat seizures? So normally in neonatal seizures, the drug of choice is phenobarbital. Unlike seizures that are seen in children, which are usually treated with lorazepam or midazolam, in neonates, the seizures are usually treated first with phenobarbital. If these seizures do not abort or do not terminate, then you can give IV phenytoin. So phenytoin can be given. In some cases, even levetiracetam can be given. If the seizures do not stop, then even levetiracetam can be given or phenytoin can be given. In some cases, they say in half the dose that you give in children, lorazepam can also be given for newborns, but only in half the dose and very carefully under monitoring. Otherwise, preferred is phenytoin only as a second line drug. Now, if seizures have been continuing and they are not stopping, which is the drug that can be given to abort the seizures? Yes, pyridoxine. Actually, both pyridoxine dependent and pyridoxine deficient seizures are known in newborns. As the name suggests, pyridoxine deficient is primarily because of deficiency of pyridoxine B6 in the body, which can be a cause of neonatal seizures. But more importantly is a gene-dependent seizure, a gene-related seizure, mutation because of a gene-related seizure, which is a pyridoxine-dependent seizure. So because they are dependent on pyridoxine, they need to be terminated only by giving pyridoxine, that too in high doses. So what is told is that basically when you have terminated or exhausted all options, phenobarbital, phenytoin, levetiracetam, lidocaine IV, all anti-epileptic options have been exhausted in neonatal seizures, it's worth trying pyridoxine because you might consider pyridoxine-dependent seizures to be one of the causes. So which of these vitamins can be given for the termination of neonatal seizures? Pyridoxine, that too in high doses. Drug of choice for neonatal seizures is phenobarbital, and drug of choice for childhood seizures are phenytoin, lorazepam or midazolam. Coming to question number 24. A typical 3 Hz spike and dome pattern. So 3 Hz spike and dome pattern means 1 spike, 2 spike, 3 spike. Spike and a wave. Spike and a wave. Spike and a wave. So seizures, EEG, drug of choice. So absent seizures, the typical EEG pattern, so very good. So the typical EEG pattern for absent seizures is 3 Hz spike plus a wave pattern, and the drug of choice for absent seizures is either ethosuximide or valproate. Then infantile spasms, which occur in infants, which is also called as the West syndrome. Typically, the EEG pattern is a disorganized EEG, which is called as hypsarrhythmia. And the drug of choice for treating infantile spasms is ACTH. If ACTH patient does not respond to ACTH, then the second line drug can be vigabatrin. First line will always remain ACTH, but if the child does not respond to ACTH in infantile spasms, then vigabatrin can be given. However, I have told in my classes that when infantile spasms occur in children with certain neurocutaneous disorders, such as tuberous sclerosis, then the drug of choice should be taken as vigabatrin. The third type of seizures are juvenile myoclonic epilepsies. Which seizures are most common in children? Well, I don't really know about the about in terms of like which seizures are the most common, but usually age group wise you can identify. For example, absence seizures typically are seen in 3 to 8 years age group. Infantile spasms are more commonly in the first year of life, so 0 to 1 year age group. Juvenile myoclonic seizures are more commonly seen between 12 to 18 years age group. So if there are different types of children at different ages presenting, then you can definitely say that this may be the most common type of seizures. But ultimately there are no set guide to which is the most common seizures in children. According to the age group, the seizures may differ. So from absence seizures, 3 to 8 years or 5 to 8 years in some books they have mentioned. 0 to 1 year, infantile spasms are more common. Adolescents, juvenile myoclonic epilepsies are more common. What is the typical EEG of juvenile myoclonic epilepsies? The typical EEG of juvenile myoclonic epilepsies is 4 to 6 hertz spike, 4 to 6 hertz polyspike and wave pattern. And the drug of choice is valproate. So just be familiar with the name of 3 important types of epilepsies, their EEGs, and then the drugs of choice. Do we have more questions, sir? So the name of this session is 25 most important questions, Nazar, and since this is question number 24, so makes sense that there will be one more question, right? The name of the session is 25 most important questions. Very good question here asked by Nazar. Is there any more questions, sir? So 24 के बाद 25 आएगा ही आएगा because there are 25 questions. Okay, there is one question, sir. Once tell about Lennox-Gastaut syndrome. See, Lennox-Gastaut syndrome is a disorder that is more commonly referred to as a disorder associated with mixed seizures in children. So any child with mixed seizures, a progressive cognitive decline, and usually a slow wave EEG pattern. Slow wave EEG जब हम कहते हैं, when we say slow wave EEG, which means 1 to 2 hertz spike and wave pattern. So a slow wave EEG pattern, 1 to 2 hertz spike and wave pattern, along with a mixed type of seizure, that means different type of seizure seen in children, and a progressive cognitive decline. That is Lennox-Gastaut syndrome. Usually intractable seizures, difficult to control seizures, multiple drugs can be used. Felbamate has been used, valproate has been used, but usually these seizures are difficult to control. Okay, coming to the last question, which of these is the most likely solid malignancy in pediatric age group? So most common malignancy in children is leukemias. Most common solid malignancy in children are brain tumors, and most common extracranial solid malignancy, all of these in children, it is neuroblastoma. So overall, most common malignancy in children is leukemias, most common solid malignancy in children is brain tumors, and most common extracranial solid malignancy in children is neuroblastomas. In children, most common extracranial solid malignancy in newborns is a sacrococcygeal teratoma in newborns. But since we are talking about children, most common malignancy leukemias, most common solid malignancy brain tumors, and most common extracranial solid malignancy is a neuroblastoma. So what is the answer to this question? Since they are asking most common solid malignancy, it will be brain tumors, which most of you have correctly answered. So with this, I thank you so much for paying attention. Answering makes our session very helpful because it means you are interacting during the class, hearing the questions during the session, you are interacting. I again repeat, I wish you all the best. I do not want to meet you people in the next session because I know you all will get selected. right? So you all are capable enough, intelligent enough, and we will not be meeting next time. We will definitely meet, but we will be meeting outside the class when you will give me good news about all of you having cleared the exam. I want to meet you then. I don't want to meet you in the class for another class session, right? So thank you so much. Wish you all the best. God bless all of you. And please do share good news about clearing your exams. Thank you very much for participating in the session. Goodbye.